The neb kits and how they come is you're gonna have the nebulizer itself, and then you're also gonna have the oxygen tube. Okay, so these are the two components that you're gonna have usually. Now, if your patient's too sleepy to actually hold the nebulizer, then there's an adapter, which is in the same packaging, that you will remove the mouthpiece, with gloves of course, and then you're gonna add this little, we call it an elbow. And what that does is it allows you to attach a mask. And this is just an aerosol mask. It truly will just fit right on that elbow, like that. And then you can deliver your neb to your patient. So there's two methods in which this will work, all right? There's this, where it's intermittent. You see this green ball there? When a patient takes a breath with a mouthpiece, this ball, because of negative pressure, will go up and down. Okay, let's say we have to use that mask though, which means they can't use the mouthpiece. We'll put that mask on and we're gonna turn the toggle switch on top so that green ball is constantly down, which means that it is constantly going to nebulize, okay? So if you're using a mouthpiece, it's just gonna be normal and it's gonna go down when they take a breath. That's the sound it makes. But if they can't do that, we're gonna turn the toggle switch and we're gonna let it run for about, it's like 5 or 7 minutes, and then we'll use the mask. Okay? So when we attach our tubing, it does not matter which end it goes to. So this one's already set up. Your O2 tubing, it looks a little different, but it's the same stuff that you would already have. It just so happens to be the type that comes with this nebulizer, okay? So one end attaches to the bottom of our nebulizer. Okay, it's gonna go right on top. You kind of muscle it on there a little bit. And that's what's gonna actually deliver the oxygen to the nebulizer under pressure, and it makes all the liquid kind of pop open into a gas. That's how this really works. So when you're going to connect to your flow meter, you want to turn it up to 7, give or take. The 7's usually the magic number, and then attach your tubing. Okay. So now what'll happen is there's a little back pressure, and your flow meter could go down a little bit. It's going to look as if it's down to 6 or 5. That's just the pressure kind of acclimating, okay? If you keep trying to turn this up, like turn it up, turn it up, turn it up, this thing will pop off. It's pretty loud. So it'll be like that, and you're gonna know. And then it jumps up. So there's just a little back pressure. When you see that ball go down, it's not a big deal, okay? And you'll know, nobody gets hurt or anything, but it's loud. When you are administering your medication, there's a few different types. Usually doctors are gonna use DuoNeb. When they say, hey, I want a nebulizer, usually it's gonna be DuoNeb, which is albuterol and Atrovent together. So Duo, think two different meds together. The really kind of universal drug would be albuterol. So albuterol opens up the lungs as well. It does it very, very quickly, but it doesn't have the long-lasting effect of a DuoNeb. So albuterol lasts for like 10 minutes, DuoNeb lasts for 4 hours. Kind of the difference. So, but if doctor says, hey, I want you to give a neb, you can clarify and say, do you want albuterol or do you want DuoNeb? Or just say, what kind would you like? But that's the difference, essentially, is one is fast acting but short term, the other is still fast acting but long term. All right, so your medication, you don't have to mix up here. Like, you don't have to take saline and mix it with albuterol. You guys are gonna get like the pre-dose vials out of the Pyxis. So when you get them, we're gonna imagine this is actually that drug. You'll twist open the top, okay? And then in your neb cup here, you're gonna squirt the medication inside. Now, do you see this hole here? Do you see that? If I have that facing down and I put medicine in here, I'm gonna get wet feet because it's gonna come right out. So when you put your medicine in, just remember gravity and that you squirt it in, squirt, 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 and that's about how much will usually be in there. Okay, it's like 3 cc's usually. And then you twist your top on. There's a hole on the end there. This hole will fit over that peg. It will only fit one way, so if it doesn't screw on, it's not on. So just put it right in there, and then you twist until it stops. It's like a half a turn. And you'll have already kind of looked at your patient and seen, are they going to be able to hold this? Are they alert enough to hold it? Or do I need to use the mask? So, like I said, both options are available to you. You would just have to grab the mask in addition to what comes with the nebulizer. And if you don't, honestly, I grab them both. I'll always grab both. If I don't use it, great. I put the mask back, but otherwise you have to leave your patient and go get it. So, what kind of questions do you guys have?
Racemic epi.
Yes. Okay, that is one you will. I'm thinking 9 times out of 10 you will have to mix that. Okay, so 3 mLs is kind of the golden rule. That's how much liquid we're gonna want to have to nebulize. So racemic epi comes in a concentrate. It's a foil package, and it's probably like that big because it's only 0.5 mLs. So you're gonna squirt your racemic concentrate into your cup, and then you will add 2.5, maybe even 3. That part doesn't matter if you have a little too much. It's if you have a little too little, because it's still concentrated. So we want to dilute the medication. Again, 3 mLs is that magic number. So if it's a little over, it's no problem. But we want to kind of stick with that. And the way that we know that our nebulizer is getting done, it kind of makes a sound. So not only are you, I mean, you guys are used to listening for stuff all the time, but the nebulizers are one of those devices where it's easier to almost listen to it than to watch it. Of course, the mist will dissipate and you won't see it as much, but our cue usually is about 5 minutes into this, it's going to start to make a sputtering sound, or that kind of constant hissing sound that is going to kind of have moments of pause. So it's going to go, that's your cue, like, oh cool, my neb's almost done. So you have about 1 minute until you could take that off. So typically nebs run for 5 minutes. And if you have it on the breath actuated, or the one where the ball goes up and down, typically what we'll do is we'll keep an eye on the clock and we'll do it for 5 minutes. You can let it run out, but because it's only breath actuated, they'll get a little bit more. It certainly won't hurt them, but those nebulizers will take longer than the constantly running ones, and that's why, because it's based on their breath and their effort.
And then when we're looking at patients who have like stridor,
yes,
how can you tell the differences? They're wheezy versus
Sure.
hypoxic versus.
So depending on what doctor you have, sometimes they roll out and they say, hey, I want a neb. You know, other times you're gonna listen to breath sounds when you do your vitals. You're gonna say, man, I hear these wheezes. So when you're evaluating breath sounds, especially for patients that were intubated, I'm gonna suggest that you not only listen to all the lung fields, but also their throat. Okay, so when we listen to the throat, we can hear if the upper airway is constricted at all. And lots of times when we extubate those patients, when we take the tube out, they do have some constriction that occurs just because it's irritating. And so for those patients, we would use that racemic epinephrine. That's that kind of go-to drug that's going to take down the swelling. Lots of times you will hear just faint wheezes in the apices, so the tops of the lungs. The bottoms will be diminished, but if you listen to the throat, it sounds scary. I don't know if you've ever heard it. It sounds like a little kid screaming. So if you only listen to the lungs, it just sounds like faint wheezes. If you listen to the throat, it sounds like the screaming sound. It's pretty intense. But then that would be indicative of a racemic neb versus a duoneb or albuterol, because duoneb, albuterol is the lower airways, and then the upper airway is going to be that racemic.
And a lot of times our thyroid patients and patients who had multiple intubation attempts need that as opposed to just a regular duoneb.
Absolutely. And you're allowed to suggest that too. You know, even based on what you hear, what you see, feel free to bring that up, because sometimes, you know, they might not have been present for extubation. They might not have seen the things that you've seen. So, yeah, you're like our first line.
Cool.
All right.
Thank you.